Good morning, everyone. I welcome you all to AIIMS Jodhpur, and I will be dealing with antenatal diagnosis and screening for rare diseases. So, Dr. Varuna has already told what are rare diseases and what diseases are included in this category. So, we know that the treatment is costly, the treatment facilities are limited. So, what is the option then? So I think prevention is the best option. And prenatal diagnosis plays a critical role in identifying the rare diseases before birth. Early detection is essential for improving the neonatal outcomes and family planning. And if we detect before birth, then it provides the couples with the informed reproductive choice. It is then their choice whether they want to continue with the pregnancy or they want to terminate the pregnancy. Now, there are two types of prevention we all know, primary prevention and secondary prevention. Tertiary is also there. So in primary prevention, 2-3 things are there. One is avoidance of pregnancy in advanced age. Any person carrier of a rare monogenic disorder not marrying a carrier, and carrier couples not reproducing. So do you think these things are feasible in the real world scenario? So these are not feasible options. So now we are left with the secondary prevention. That is the avoiding the birth of the affected fetus by doing prenatal screening and prenatal diagnosis, early detection of disorders, and if the disorder is detected, then appropriate timely medical intervention to minimize the manifestations, and that we can do by newborn screening. Now, what are the options which are available for prenatal screening? So, basic objective of prenatal screening is to identify the high-risk mothers who are likely to be affected or are likely to be giving birth to an affected fetus with a rare disease. So, we have different screening options. One is the screening for aneuploidy, which we are commonly doing because nowadays the age of marriage is increasing. The people are getting married at an advanced age. They are giving birth at an advanced age. So chromosomal abnormalities, they are very common. And the other one is the single gene disorders, which are quite common in cases where the consanguineous marriages are there. And even if the marriage is not consanguineous, then also there are certain conditions which are common and which can be seen. So for these aneuploidy screening, we have biochemical screening, which we are commonly doing. We have the USG based screening, where we can see the soft markers, we can see some markers, major and minor markers, which can give us an idea whether this female is a high risk for having a baby with aneuploidy or Down syndrome. Then there are certain ultrasound markers which tell us that this baby might have some syndromes. And then there is history in the family that this is a consanguineous couple having a history of a previous baby who is affected with the rare disorder, or the couples, they have been tested because there is some history in the extended family and they are found to be carriers. So these are the screening methods which we are doing. Then there is another test, non-invasive prenatal testing. So it's a new frontier and it's a non-invasive test. By the blood test, simply we can detect or screen the high-risk cases for aneuploidies. Then there are expanded carrier screening. We are living in a belt of thalassemia, sickle cell anemia. So these are very common diseases which you may be finding these cases not even in the consanguineous, but even in the non-consanguineous marriages. So it's a very common condition, a single gene disorder, thalassemia and sickle cell anemia. So for that, expanded carrier screening can be done. Now we have screened the high-risk cases that these patients, they are likely to have an affected baby. Now, how will we diagnose them? So for that, we have certain prenatal invasive procedures, which we are doing during the antenatal period. And by taking the sample from the fetus, we can diagnose certain conditions. So we have embryonic villus sampling, which can be done at 11 to 13 weeks of gestation. Amniocentesis, which can be done at more than 16 weeks of gestation. And we can also do cordocentesis at more than 18 weeks by taking the fetal cord blood. And then these tests, the samples, they can be sent for the various genetic tests. Now, just to show, because we have obstetricians from different places, and I get a call every day, we want to start fetal medicine in our department, we want to start amniocentesis. So what is the procedure? How can we do these things? So just for them, I have just shown what all minimum things are required in the amniocentesis. It's a simple procedure, but it needs practice, and you need certain, there are certain guidelines. PCPNDT Act is there. You have to perform certain number of procedures before you are going to start these procedures. And the most important thing is that doing the procedure is not sufficient. You have done the procedure, you have taken the sample, but before that, the pre-test counseling and the post-test counseling is very important. What genetic test you are prescribing, that is very important. And you have to give them all the options. What if the disease comes out there, or if the baby is a carrier, or the baby is normal. So it's not one thing that you are now expert in doing a procedure, so you are doing the procedure. So you have to do all the things, the pre-test counseling, the post-test counseling, and if the female wants to deliver the affected baby, then what are the interventions that can be beneficial for that baby? So those things you must know. So this is a small video of how this procedure is done. So a small needle is inserted and we take out the amniotic fluid from the uterine cavity. And that fluid can be sent for the sampling. Then if a patient comes to you very early, so you will not wait till 16 weeks for doing an amniocentesis. You can do the chorionic villus sampling. So you can see here, this is the placenta, and you can just insert the needle in the placenta and aspirate the chorionic villi. And these chorionic villi can be sent for testing. And this test result comes within 2 to 3 weeks. There are different tests, there are different timelines. So by 14, 15 weeks, you are having a diagnosis in hand, whether the baby is affected or not. So that if she wants termination, that can be done timely within the scope of the MTP guidelines. This is the cord blood. This is the umbilical vein from which the needle is inserted and the fetal blood can be taken. Then suppose that is missed in the antenatal period. The baby has delivered, or the patient has come to you late and there is a history in the siblings, or there is history in the family. Then it is very essential that when the baby is born, you do the newborn screening. So basic common tests can be done, and then you can do the targeted screening based on the history of the patient. So that is very important, and we are doing in our institute also, we are doing the newborn screening for at least some common conditions which can be treated and which can be investigated and treated. Then early postnatal diagnosis and treatment. If there is no facility of doing the test in your setup, then it is always better that if such patients with a positive history are there, you timely refer them at a center where their diagnosis can be made, where the screening can be done, where the interventions can be done timely. So timely early postnatal diagnosis and treatment is very essential, because this will reduce the morbidity to a much greater extent. Then again, tertiary prevention. If you have diagnosed a condition, suppose DMD, SMAs, so at least whatever life the child is having, that should be free of morbidity. So early referral, early diagnosis, early treatment will be beneficial. So we have a model intervention center where at one place, all the things, they can be covered. Now, we have done the screening, we have done the prenatal diagnosis, we have the sample, amniotic fluid, we have the chorionic villi sample. Now the dilemma is, which genetic test should we choose? So for that, either you have to send the patient for a genetic counseling, so that prior to the testing, you know which test you are doing. Accordingly, you will take the sample and send it to the lab. Or you must yourself know the basic things. So we have karyotyping. You all know karyotyping. That is for basically the chromosomal abnormalities. So you can just see, this is my favorite slide. And this is a just shelf of books. So if you remove any book from this shelf, you know that there were 24 books and you have removed one or you have added one. So that is basically the karyotyping. So you have detected the aneuploidy. Then there is chromosomal microarray. You take out one book, there are 100 pages. If somebody has torn one page, so you need a more higher resolution testing to see which page is torn. So to find out the micro deletions and duplications, there is chromosomal microarray testing. Then from that particular page, which one word is deleted. For that, you need clinical exome or the whole exome sequencing. That will tell you which gene is affected, right? And then there are targeted tests. You know previously that the mother or the father or the sibling has a Tay-Sachs disease or the Pompey's disease. So that particular variant, you just want to find that particular variant. So you will just do Control F and find out that variant. So that is the targeted testing, which we can do by Sanger sequencing, or we can do by MLPA, FISH, or QFPCR. So these are the different types of tests. These are the timelines. The QFPCR and FISH, these are rapid tests. Patient comes to you at 20 weeks, 19 weeks. So you just want to do a rapid test to know whether the patient has aneuploidy or not. So the result comes within 48 hours. Karyotyping, this requires culture. So it will take around 2 to 3 weeks for the report to come. So if a patient is coming to us at 20 weeks, at 19 weeks, there is no time for only karyotyping. So we send the sample for QFPCR as well as karyotyping, so that timely we know whether the baby has Down syndrome or not. Then the microarray again comes in 2 weeks, and NGS is next generation sequencing, which we generally prefer for monogenic disorders, which come under these rare diseases. So now you see it takes 4 weeks for the report to come. And it is very difficult for us because the patients, they come to us at 19 weeks, 20 weeks. Now, if we do a prenatal testing at this point of time, it will take 4 weeks for the report to come. And then she will be 24 weeks, 26 weeks. Then the law does not permit MTP, or you have to form a medical board for the MTP. So it is very important for us that this workshop is basically planned that we must be aware of such conditions. So when a patient comes to us on the first visit, we take a complete history, we just evaluate whether she is high risk or not. And at that time, or if something has happened in this pregnancy, then we can just call her for the preconceptional counseling, so that we save time when in the next pregnancy. She is aware that in the next pregnancy, she has to come at 3 months and go for testing whether the baby is affected or not. So this empirical genetic testing in the prenatal cases is not useful. Without a known target, we cannot keep searching the genetic data, because pediatric cases may we have the patient in front of us. We can see the phenotype. But in prenatal cases, the baby is inside. We are not able to see the phenotype. If we randomly do any testing, then it is very difficult to see whether it is pathogenic or it is a variant of unknown significance. So the preconceptional counseling concept should come in our practice. And again, these are the challenges in antenatal diagnosis. There is so much complexity in genetic counseling. We have so many tests. somebody will counsel that go for whole exome sequencing. The patient will go to another doctor, she will say, no, you go for clinical exome. No, you go for this test. So a lot of screening tests are there. The cost issues are there, financial problems are there, excess in equity. All patients, they cannot go for testing for all these conditions. But it's a good thing that nowadays the costs, they are coming down. And then there are ethical considerations. The fetus is considered as an individual patient, whether the fetus has his own rights or not, whether we are able to take the decision on behalf of that fetus. So there are ethical considerations also. Then while doing the testing, again, there are challenges, decision challenges. Is the diagnosis right? Whether it is the right time to do the procedure or not? Whether access to the fetus, placenta is posterior, we are not able to do the chorionic villus sampling. We have to wait for amniocentesis, right? So technical challenges, laboratory challenges, and the most important thing is अगर research, if we see, so प्रेग्नेंट पेशेंट्स पे RCTs वैसे ही बहुत कम होते हैं. तो जो भी हमारे पास डेटा है वो केस रिपोर्ट्स, केस सीरीज से ही हमें मिलता है ना. तो कोई बहुत बड़ा हमारे पास कोहॉर्ट्स एंड ऐसे स्टडीज हमें कम ही मिलती हैं. तो वॉट एवर वी हैव थ्रू आवर एक्सपीरियंस, क्लिनिकल एक्सपीरियंस. So now just this is the data from our institute. We started doing these procedures in 2019. Until 2024, we have done around 1,221 invasive procedures. Maximum, they are amniocentesis, and then some are this chorionic villus sampling. We have done the advanced procedures also, but for diagnosis, these two procedures were the main. Then the common indications for which we have done these procedures were, in the ultrasound, we found absent nasal bone, which we know that is a marker for Down syndrome. Then the family history of single gene disorders, or there are some structural defects in the ultrasound. There are soft markers. Some of the cases we have done for advanced maternal age. The age of the mother was more than 40 years, IVF conception. So in those cases, we had to do these tests. Then maximum cases were, they were screened during pregnancy. They were found to be high risk for having aneuploidy. And to detect those aneuploidy, we have done those screening tests. Again, hemoglobinopathies. This is a belt, thalassemia-prone belt. So we have done a lot of cases for hemoglobinopathies. And then non-immune hydrops. This is one big entity where no single cause is there. It can be because of monogenic disorders. It can be because of aneuploidies. So a lot of cases have been done for NIHF also. These were some interesting cases. This first case, this patient presented to us with non-immune hydrops. And when we did the ultrasound, you can see here the bladder was distended. We thought that because of this distended bladder, there is pressure and the baby has non-immune hydrops. Then this patient came to us at 30 weeks. Now, can we do amniocentesis at 30 weeks? We can do. There is no limit for amniocentesis. MTP के लिए है, but amniocentesis के लिए नहीं है. Because अगर हम 30 weeks पे इसकी diagnosis कर लेते हैं, तो by the time the baby delivers, we have the diagnosis in hand and we can start early treatment. Otherwise, we'll have to wait for 1 more month for the report to come. So this patient had a diagnosis of Brugada syndrome, which is a very rare syndrome, and it is characterized by arrhythmias. But luckily, this baby survived, and the patient has sent the photograph of the baby after 8 months. After birth, the echo was done, the ECG was done, it was all normal. So we are following this baby, and we hope that this baby will have a good outcome. So it's not so that all genetic diseases, they have a poor outcome. Then this was another case, which again presented with non-immune hydrops. There was tricuspid regurgitation, there was ventriculomegaly, there were brain calcifications. So we thought that this patient has some torch infection. Toxoplasma हो सकता है, CMV हो सकता है, but the test was negative. We did the amniocentesis. Again, we have done this amniocentesis at around 26-28 weeks. The amniotic fluid पे जो torch किया वो भी negative था. Then we also sent it for whole exome sequencing and we found that it was Aicardia-Gouttiere syndrome. So this baby unfortunately did not survive and the baby delivered preterm and this was a stillbirth. Then these were some cases. The sibling had a Tay-Sachs disease. Then we did the CVS at 13 weeks and the current fetus that was found to be carrier of Tay-Sachs. So at least parents were sure for the rest of the pregnancy that the baby is not affected. This was the first baby had features which were similar to Cornelia de Lange syndrome. The facial profile was, you can see in the image also, there was micrognathia and the facial profile was not fine. So we did not have any genetic diagnosis. She came at 20 weeks. So we did the testing and the testing was done simultaneously for that affected baby also and for the prenatal fetus also. But unfortunately, there was no variant was found, no cause was found. But still, the two babies have the same features, same affected features. So maybe in future we have some more different tests, some new disease might be there, which is not in our database right now. So it is very important whatever we diagnose, we enter in the registry so that we have the database of our rare disease cases. The disease which is not known now maybe come in that category after some years. Again, these were some cases like congenital nephrotic syndrome. You can see from this pedigree, all the babies were affected, right? And recently, she conceived for the 5th time, and again the 5th baby was affected. So now the patient was like, what to do now? Every time we are going for the test, and the baby is affected. So any option for this? So she can go for IVF because both the parents, they are carrier. So either they can go for ovum donation or they can go for sperm donation. So this is one option by which we can have a healthy baby. So these were different diseases that we have diagnosed prenatally. Brugada syndrome, Gaucher's disease, Krabbe disease, Pompe, SMAs, DMDs, this Noonan syndrome, hyperhomocystinuria, Wheeler-Najar syndrome, nephronophthisis, nephrotic syndromes. So the message is that prevention and early diagnosis and intervention will bring light in the darkness of these rare diseases. And future directions, sir has already told what are the policies and what initiatives are being taken from the government. And I thank my patients and the institute for encouraging us for doing all these tests, and we are able to give hope to a lot of patients. So we thank them all. Thank you. Any questions? Yeah.
As we have learned from this presentation, and already know that primary prevention is better than secondary prevention and should be the main focus for breaking down all the burden associated with these rare diseases. So my question is, it may have some medical legal aspect as well. That we know that the age cutoff for MPP has been advanced to previously 20 days, 24 weeks. So my question is that this in near future it can be expected to be increased further to 24 weeks, and what is the safest age limit for MPP without causing maternal harm? And one more thing about prenatal invasive tests we have discussed, like anesthetist or photosynthesis. What are the features associated with this? Supposing we have healthy fetus who is inside in uterus and we do suspicion of cosmetic problem, we do photosynthesis for photosynthesis. And what are the features associated with that? And how safe is up to what upper age limit can be these invasive procedure done, or MPP can be done without causing maternal as well as fetal harm?
Yes, so the recent act, the MTP Amendment Act which came, so it says that even up to 24 weeks, the MTP can be done, right? For all the cases, up to 24 weeks we can do, but after 24 weeks, the difference is that before 24 weeks, before 20 weeks, one medical practitioner can sign, and after 20 to 24 weeks, two medical practitioners, they have to sign. So after 24 weeks, for congenital anomalies, which are lethal and not compatible to life, the termination can be done till any gestation, right? So in many places, these terminations, they are done. But the thing is that when we terminate at 28 weeks or 30 weeks, so the baby will be born live, right? So you cannot leave that baby. You will resuscitate that baby. So there are currently no guidelines that while you are terminating the baby after the viability period, infrastructure and resuscitative procedures for incompatible fetus, they are not wasted. The resources are not wasted, and the parents also, they get an attachment even if the baby lives for 1 day or few hours. So the parents, they develop a bonding with that baby. So these things are not clear in the guidelines. The people are approaching, maybe in 1 or 2 years, we have the clear-cut guidelines and clear-cut list of anomalies for which we can do the MTP. Then the second part was invasive procedures. They can be done at any gestation, right? Because there is no cutoff. We can do at 30 weeks also. We can do at 32 weeks also. So there is no cutoff. ठीक है? और आपका क्वेश्चन था कि कितना रिस्क है? थर्टी फोर वीक्स पे तो MTP क्या, वो तो फिर डिलीवरी हो जाएगी. हाँ, वही अभी गाइडलाइंस में नहीं है कि हम बेबी को ऐसे कर सकते हैं या नहीं कर सकते हैं, है ना? एंड these are मतलब ह्यूमन राइट्स और इलीगल एथिकल, यही सारी प्रॉब्लम्स हैं इसमें. सो वी कैन नॉट, यू कैन जस्ट आस्क द पीडियाट्रिशियंस, हम बोलेंगे कि नहीं ये बेबी सर्वाइव नहीं करेगा, बट दे विल से दैट वी कैन नॉट लीव द बेबी एज सच. Whatever life, 1 hour, 2 hour, जितना भी है, we have to give support and comfort to that baby. We cannot leave that baby as such. Right? But the thing is that 38 या 32 weeks पर अगर हम डिलीवरी करा रहे हैं, तो डिलीवरी में the patient can land up in cesarean. Then the thing is that we are doing a cesarean for a baby who will not survive. तो इसीलिए guidelines 24 weeks तक रखा कि safer limit is 24 weeks. But still, if there is only for congenital anomaly, not for other reasons, मेडिकल रीजंस हो, सेक्सुअल असॉल्ट के रीजंस हो, कोई भी अदर रीजंस हैं, उस पर 24 वीक्स के बाद अलाउड नहीं है, बिकॉज द सेफर लिमिट इज 24 वीक्स. बट फॉर कंजेनाइटल एनॉमलीज, बिकॉज इट इज कॉजिंग लॉट ऑफ डिस्कम्फर्ट एंड डिसेबिलिटी, lot of this problems to the couple, so this timeline has been changed from beyond 24 weeks only for congenital anomalies. And if we are doing these invasive procedures, the risk of abortion after doing an amniocentesis is just 0.1%, 1 in 1,000. See, thank you.